Good morning, everyone. Buenos dias. As Mary said, my name is Cindy Comerford. I work at the San Francisco Department of Public Health, and I work in the Office of Planning and Policy. So I work on a whole range of health policies, but mostly policies around the built environment, how our environment impacts our health. So issues around land use, transportation, and also around climate change. About 5 years ago,
May I help you?
oh, sure. 5 years ago, the Department of Public Health got funding from the CDC, which is our Centers for Disease Control, which is the federal health agency in the United States. And we started our climate and health program. And so I'm the director of this program, and today I'm gonna kind of go over kind of our strategic framework of our program and how we're trying to build public health resilience to climate change in San Francisco. How many people here work in public health? Okay, not too many.
Sorry.
That's okay. Do you want me to get it? I think I can get it here. Let's see.
I don't know if it's.
Oh,
Yep. Down here.
okay, here we go. 1 second and we'll be up
There
and
you go.
going.
Perfect.
So what I'm going to do, I don't have cards, but my contact information is on this slide. I'm going to just start off quickly talking about the public health impacts of climate change. So the way this slide is organized, it kind of shows the climate hazards that we're seeing over time as climate change kind of escalates and unfolds. So we're seeing sea level rise, increasing CO2 in the atmosphere, rising temperatures, and extreme weather events. And we can see those direct impacts, some of them which are very well known around extreme heat, heat mortality and morbidity, air pollution, some of severe and fatal injuries from extreme storms, and then some other health impacts that have been less studied but are just as prominent as important. So we're seeing a lot of mental health impacts, specifically in more island nations or tribal nations. And also I think there's been some discussion, and there's going to be a panel session about migration. So as we see our cities that have to retreat because of sea level rise, degradation of our food supply, we're going to see more forced migration that is also going to impact people's public health. So this kind of shows a broad range of the health impacts that we're seeing around the world. In San Francisco, the major impacts that we're looking at are extreme heat, flood, inundation, and extreme storms, air pollution, and changes in vectors, specifically around increases in allergies and asthma. And so our program has about 5 elements to it that I'm going to briefly speak about today. So I'm going to talk about data analysis and assessment, emergency planning, education and outreach. I'm going to talk about collaboration with our other city departments and also stakeholder engagement. So one of our first projects we took at the health department was to create a climate and health profile. And our climate and health profile kind of looks at San Francisco, looks at the climate projections and its associated health impacts, and also its direct impacts on vulnerable populations and our neighborhoods. I'm going to quickly kind of show you the website that we developed for this report to give you kind of an idea of how we were trying to really look at our climate projections on a micro level to look at our neighborhoods. If this works, let's see. Actually, I'll keep going. I'll kind of, and so what we did in addition to creating this website, we created a community resiliency indicators. And so we looked at our kind of variation within our neighborhoods in San Francisco to see our most resilient neighborhoods and our less resilient neighborhoods based on 17 different indicators. So we can kind of start doing our planning within San Francisco. So based on this kind of overarching assessment, we started to drill down and do more detailed assessments. And our first detailed assessment we did was on extreme heat. And what we did is we took a very comprehensive approach to looking at heat vulnerability in San Francisco, and we looked at social and economic vulnerability. We also looked at more the physical environment around housing and air quality. And then also we took remote sense data and kind of combined them in an index using a statistical analysis around principal component analysis. And we came up with this final indice, which you can see mapped out here. And this kind of became the basis for doing education and outreach, which I'll talk about, and our collaboration with other city departments. And I'm going to kind of use the heat as an example as I move forward. But in addition to heat, we also just completed our flood vulnerability and extreme storms assessment, where we kind of did the exact same thing, where we looked at all the social vulnerability indicators, environmental, and climate change indicators. Sorry. Oh, a little late. We'll go back to the slide. There we go. And in addition, I'm not going to show this right now because the internet seems to be a little slow, but we took the report and we made this interactive story map. And we've also created some educational materials off of this report. So we're trying to look at different ways that we can communicate our climate information to other city departments, our residents, and nonprofits. And so those were some of the data assessments that we've done. Emergency planning. Our climate and health program in the Department of Public Health is a collaboration between two branches within the Department of Public Health. So it's the Office of Planning and Policy and also our Public Health Emergency Response and Preparedness Unit. And so we've worked together to create these emergency preparedness plans. We've done one on extreme heat and also one on flooded inundation and extreme storms. And what we've done is we've created a response plan with our Department of Emergency Services, which we didn't have up until a couple of years ago. And we started planning for having medical shelters, cooling centers, and how we can have a response to these events that have been typically infrequent in the past, but with climate change are increasing in frequency and severity. We've also, along with our assessment and data analysis reports, we've created an education curriculum. And so part of our strategy is to do education to our residents and other providers of services within San Francisco. So we've worked hard to kind of come up with different and unique messages to educate people about the health risk of climate change and also the specific climate hazards that are happening. One of our most important program tenets is our collaboration with other city agencies. As we know, climate change is not specific to any one department within a city agency. So we've worked with our Department of Environment, our planning department. We also participate in the 100 Resilient Cities initiative. So we have a chief resiliency officer, which is kind of spearheading our resilience strategy. And so it's been really important for all of us to collaborate together, which has been it's a little difficult. In our city, we have 28,000 people that work in San Francisco. So we have been more and more coming together to solve these complex issues. And lastly, one of our big things, not only collaborating with city departments, but outside stakeholders. Our resources within public health, as most public health departments, are somewhat limited. And so we've partnered with tech companies which have created this kind of asset mapping platform to help neighborhoods collect information and prepare for times of stress. We've done a lot of work with neighborhood empowerment networks, different nonprofit organizations to help us further our reach into the community to help them prepare for climate change. And kind of our takeaway from our work over the last couple years and measuring our impact has been one of our things that we've done is really simplify the science. We try to take the climate science, which sometimes presents uncertainty to people, and make it simple for people to understand what's happening now, what's going to happen in the future, where it's going to happen, and how it impacts your health. What we found for people and residents, place-based information is really important. What is going to affect you and where you live. we found the indice maps that we've created that had a huge impact on communities, that when they saw risks in their areas, they were able to understand what was going on, and there seemed to be a call to action, which was really important. Just working with the community, the really importance of personal stories and experience, of trying not all to make it about data and high-level climate projections, but try to understand, taking stories about neighbors that suffered from heat stroke or people who have suffered from injuries during floods in water only 6 inches high, really how this could impact their health or their children's health. And being in a health department, one of our most specific focus is really on vulnerable communities. So we take health equity very seriously, and one of our goals is really emphasizing the impact on vulnerable communities and how we can take steps to help them. And so that's an overview, thank you, and we'll be able to answer questions at the end.
Thank you very much. And really simplifying the science is a fantastic message. And this interactive story map is really interesting. I hope that we'll all follow up. I think I'd like to ask Luciana to come now and speak. Our two visitors probably should speak before our two local Barcelona representatives.
Good morning, everybody. My name is Luciana Neri. I'm the resilience manager of the city of Rio. And supposedly I'm going to show, it's coming. It is slow. Okay, so my presentation is managing dengue fever and Zika in the case of Rio de Janeiro. I think this is something that's dengue has been in our city since 1981 at least, but it's become even worse because of Zika. And just to give you a context, so Rio is a city of 6.4 million people, the second largest city in Brazil. We have in the metropolitan area about 11 million people. 1.2 million people live in slums, and basic sanitation covers 50% of the area. I would say today 52. It's situated by the sea. We have 3 large forested mountain ranges. You can see the forested mountain ranges over there. It's a big asset. Almost more than a third of our territory is covered by forests, and they are true forests. We are a mega city with multiple levels of government. It used to be capital of Brazil since 1960. We hosted the World Cup and we hosted the Olympic Games in 2016. So right now the world really is looking at us. And so this is the big question. I love this, we are making it suffer. Yeah? And so Zika right now is a challenge for science. So little is known about it. It's not known about it. And we do not know, for example, the full extent of its effects on human health. We don't know exactly the modes of transmission. We know there is mosquito, sexual transmission, perhaps saliva, but we don't know the exact numbers. We don't know why some women who are pregnant, they develop extreme forms of fetal deformation and some don't. So because science is still trying to figure out what Zika is, governments come after it. So right now, the only form we have to deal with it is eliminating the mosquito. That's the only thing we have in our hands. We don't have yet vaccination. We don't have yet any kind of anything else other than killing the mosquito. And of course, it's a challenge for people. 80% of all the mosquito breeding grounds are inside households. And we cannot aim to change people's behavior if we don't even know the full extent of it. So, and because we've been dealing with dengue since 1981, we have not been able to eliminate it. So, a few numbers. Regarding Guillain-Barré, which is a disease of the nerves, it starts with bottom paralysis. We have had 1,868 cases in Brazil in 2015, which is 28% more than 2014. We don't know exactly how many are linked to Zika, but that's a strong suspicion. The second number is that 29% of Zika-infected pregnancies will develop fetal deformations. So not all pregnant women who develop symptoms will have problems in the fetus, but we don't know why. Also, cases of microcephaly, 745 confirmed cases in Brazil and 157 deaths, confirmed deaths here. We have more than 4,000 suspected cases of microcephaly. And which, is it good news? I don't know, but only 10% of infected mosquitoes are able to transmit Zika. So in laboratories, there is artificial transmission of Zika to mosquitoes, and only 10% are able to infect people. However, yellow fever is even less, and even then there are epidemics of yellow fever. So it's really a matter of infestation. So that is why, in the next numbers is, so okay, so what have you been doing? So this year, all those numbers are about 2016 in Brazil, the ones in to the right. So 48 million households have been inspected in 2015. There are 318,000 people permanently employed health agents. Not only that, but we also have 220,000 army personnel working on Zika. 78,000 schools mobilized until March 11th. That's the most recent number. 27, that's about 45 million people reach when you talk about kids and their families. And the level of infestation right now is 3.36%. That's a lot. Our goal is to reach 1%. Why? Aedes aegypti, which is the mosquito that transmits dengue, is endemic. So we do not, considering that we are a tropical country, we do not expect to truly eliminate it. Now, in the city of Rio, specifically, we have had more than 10 million visits to households in 2015, so last year. We have 3,200 agents fully dedicated to it. The preventive actions have been happening year-round since 2002, even though the cases, they have most cases in the summer. It has to be a year-round action. And more than 80% of all breeding grounds are inside households. And now, so per week, 200,000 households in the city of Rio are being inspected. But it's not every household. So level A, those are perhaps apartment buildings, so there are 2 to 3 visits a year. Level B, 5 to 6, and level C, every 15 days, right? And also the fixed points. We have 480 fixed points, permanent staff, transportation hubs mainly, or stadiums. Those are a few numbers. There's just a number of dengue cases from year 2000 to 2016. This is not, so in March we had, until the first week, 23 cases. You see that the first semester, you have lots of cases. In the second semester of the year, not so much. And there is a wide variance here. It's also a biological fact, the science does not know yet, that the Aedes aegypti has some sort of 2 to 3 year cycle for breeding. No one knows. Of course, there are always the impacts of extreme heat and humidity. So it's a conjunction of things. So why do we have so much variance? It's weather. The thing is, if the mosquitoes, if it's too hot starting October, the mosquitoes starts breeding too fast. By January, you have the epidemics. You see, but depending on if it starts later, then you have fewer. So this is, judging by the last 15 years, month by month. This is January, so you have Good news, the Olympics will be in August and September. Yes, and which are the lowest infections. So it's not zero. It's not zero, and if we return to August and September, it's not zero, but it's much lower, right? And, well, this is the place where I work for. This is the Center of Operations Rio. We have 30 departments there. One of it is the epidemics department. They follow the spread of the virus in the map, so they can warn the population and intensify inspection actions. Okay. Okay, so how about the Olympics? So we have been working for dengue prevention and now Zika prevention for one whole year. Permanent monitoring of air quality, and now that's a catch-22 situation here, because good air quality means more mosquitoes. They breed more. So they can breed up to 88% of mosquitoes. They are going to erupt, the larvae, they erupt in good air quality. If it's polluted, depending on the kinds of particulate matter, only 55%. So, but we are not counting on that, right? So, also there are weekly implementation of baits. Baits are pretty much like, it's like a glass of water, just clear water, and some grass inside with pheromones to attract mosquito. And they stay there for 6 days, which is enough to attract, but not enough to have them breeding. So you count, and the scientists, they can identify Aedes aegypti and Culex, Culex is the most common mosquito. So by extrapolating, they can pretty much guess what is the infestation level of the area, right? And also identification of likely deposits, elimination or management, obviously, and fixed agents and reinforcement twice a week on nearby transportation hubs. So airports, train stations, bus stations, stadiums, because stadiums, people are close by, and people come from all over, so they bring all kinds of illnesses with them, and you have mosquito here, so all kinds of vectors must be very cared for here. And one thing is, which is the motto that we're saying, is that a mosquito is not stronger than a whole country. So it is difficult, but we are expecting the best. Perhaps Zika came as a big wake-up call that, you see, science is following, but what we have in our hands now is the elimination of mosquitoes, so we have to focus on that, and that's what our resilience efforts are at this point. Okay? Thank you.
Thank you. And what's very, very interesting in how you talked about dealing with scientific uncertainty. Yes. In public health, we know we have scientific uncertainty. We can't just stop them. We have to act. So this is a great example. So we move on now to, we'll ask Javier to come up and give us a presentation on a couple of 9 European cities.
Thank you. Yes, so I come from a different sector. I come from the research part, and I work in a research center, and what I'm going to present are the results of a research study trying to assess how the preventive plans for heat waves, to prevent the health effects of heat waves, work in 9 European cities. So first, a bit of background. You know, in Western Europe, we had this mega heat wave in 2003 that had very devastating effects. So some studies have quantified that there were 70,000 excess deaths during that summer in Western Europe. And this was an eye-opener for Europe on the potential effects of heat on health. So the next year, several European countries introduced preventive plans to prevent those effects. But we actually know that temperature affects mortality not only during heat waves, There are many studies looking at the relationship between temperature and mortality, and well, most of them, they found this shape. So this is for Barcelona, but it's very similar in many parts of the world, where we have a temperature or a range of temperatures of minimum mortality, and then when temperature goes up, then mortality also goes up, or when temperatures get colder, mortality also increases. So there are deaths related to temperature that actually do not occur during heat waves. So the aim of this study was to assess the relationship between temperature and mortality before and after 2003. That is when many countries introduced the health plans. And for that, we did that in 9 cities, in Athens, Barcelona, Budapest, Helsinki, London, Paris, Rome, Stockholm, and Valencia. There was a bit of heterogeneity in these cities in terms of preventive plans. Many of them introduced preventive plans in 2004. They were national plans, most of them. In Barcelona and Rome, there was additionally a regional plan with more measures. In Budapest, they introduced the plan in 2006. And then in Athens and Stockholm and Helsinki, they don't have a preventive plan. This is just to show we're comparing 2 periods, period before, 7 years before 2003, 7 years after 2003. And this is a comparison of the temperatures. So if the 2 lines are on top of each other, it means that the 2 periods were quite similar in terms of temperatures. And this is the case for most cities, except for Barcelona, where we see that in the period after 2003, the temperatures were 2 degrees warmer, and also a little bit in Rome, where the temperatures were about 1 degree warmer. And this is the comparison of the shape of the relationship. So we would have the risk of mortality in the y-axis and the temperatures in the x-axis. And for example, if we look at Rome, so the red line is how mortality increases with temperature in the period before 2003. And the blue line is how it increased with temperature after 2003. So we see that it increases in a much slower pace, and this is what we expect if a preventive plan is working. So this is the pattern we expect. We see something similar in Paris also. Mortality now increases in a much slower pace with temperature. And also in Athens, we see the same pattern. Barcelona is a little bit different. We see that now in the second period, the blue line, we start to detect effects on mortality at warmer temperatures, so there is some acclimatization to warmer temperatures. But once mortality starts to increase, it increases in the same pace than in the previous period. And then we have other situations, like in Helsinki, for example, where in the second period, there is a much stronger association of heat with mortality. So we have a little bit of everything. So these were, from those curves, we tried to estimate numerically what are the gains on preventable deaths. So we could calculate the deaths attributable to temperature before 2003 and after 2003, and in this column we have the change in attributable deaths due to temperature. And the ones that are in bold font, that I don't know if you can appreciate that, are the ones where we see a significant improvement. So in Athens, there is a reduction of 1,000 deaths per year. In Rome, there is also strong reduction, and in Paris, there is also strong reduction. But for all the other cities, we don't detect significant changes, and even in some of the cities, we see small increases. The interesting part here is in the last column, we have whether the city had a plan or not, a preventive plan or not, and for example, we see that Rome and Paris, where we detect these improvements, there was a plan, but for example, in Athens, where we see the stronger effect, they actually don't have a preventive plan, and they have observed this reduction. And in other cities that actually do have a plan, we are not seeing a change in the number of heat-related deaths. So, in summary, we have seen that some cities do have experienced a reduction in heat-related mortality after the introduction of the plans, but we have seen the reduction also in a city that didn't have a plan, like in Athens. And on the other hand, we had cities that actually introduced preventive plans, but we don't see a reduction in heat-related mortality. This shows that actually the evaluation of this kind of programs is difficult. The plans are heterogeneous in different places, and there are a lot of other things that can change from one year to the other, or the temporal changes that change at the same time. So the introduction of the health plan is not the only change that happened during those years, and there are things that we are not controlling, like, for example, some studies suggest that if the influenza epidemics in the previous winter were mild, then this will result in more frail people making it to the summer, and then we would see a stronger effect of heat. So this was part of this PHASE research project. If you are interested in knowing more details, you can go to this website, and the results that I presented are a summary of what is presented in this scientific paper. That's it. Thank you.
Thank you very much, everyone. Thank you, and we'll take questions at the end. But this obviously shows the difficulty of evaluating this type of research. And one could ask, well, what differentiates those different heat plans? Were they targeted? Were they not targeted? Et cetera. But thank you, and we'll call now Juan Ramon.
Well, thank you. Thank you all for being here. What I'm going to try to do is to explain a little bit of how in the city of Barcelona, in the public health agency where I work, and where we started a few months ago, working group integrating people from different divisions of the public health agency. 4 main issues have to do for us. Of course, everything that Cindy was saying with that nice will before is still true. But in our context, which for our climate and for our level of development, we expect the problems to concentrate around heat waves, water quality and availability, and of course we're in Mediterranean shore, so water is a scarce good in our context, with air quality and with vector-transmitted diseases, which essentially for us means mosquito-transmitted disease. And of course, as it's been said before, the heat wave of 2003 was an eye-opener. Mortality doubled in the city of Barcelona, more than doubled, in fact, that summer. And it was really a different thing. And we realized afterwards, I mean, at that time, well, it just, the elderly frail were going because of during the extreme heat. But when we look back at the epidemiology and who and where, it really was a turning point. And afterwards, as we've had this heat wave planned responses with a warning system. It's part of the municipal emergency plan since 2004, and the warning activates action for primary healthcare teams and for social services and for nursing homes, but it's partly a black box. We don't really know what happens at the end and to what extent the actions that should be taken are actually taken other than general tales about drink more and try to be with air conditioning or try to get away from extreme heat. But we monitor daily funeral services in town during the heat waves, and we have never had, again, something comparable in size to what the 2003 heat wave was, but as Javier has shown, the patterns are not that encouraging. So that's something we should be working more, and we've been inspired by the work of San Francisco, and Anna, who's here, has been looking more and more at data at the neighborhood level, and even in the future perhaps at the block level, so we can see that mostly from other studies, the vulnerability to heat waves has to do with the proportion of the elderly living alone, the frail elderly, and also with the income. I mean, the poorer people suffer more from the extreme heat events. So we'll have to see how this can be dealt with. Now, thinking about air and thinking about water, and of course, air, water, and places is a classic of public health that we all study when we get our Masters of Public Health degree. It comes from the Hellenic tradition. But air pollution in the city is mainly caused by traffic. And we do have action plans for the area, and climate change impacts because we have less rainy days. The interaction between nitrous oxide and ozone gets worse, and we might have wildfires. We haven't had wildfires near the city in the recent past, but we have experiences in California or experiences in Moscow not too long ago that show the huge impact wildfire can have on urban pollution. And regarding water quality, we do have periodic droughts, and it's getting worse. It's more frequent and it's more intense. And so far, although the amount of rainfall is similar, it concentrates in less days of precipitation. So, and we have very limited sources of drinking water in the Mediterranean basin. Most of our drinking water is surface water, which means it may be polluted. Or used several times in a row. We had a very serious drought. And because of the European standards, the European directives, and the very serious drought in the 2007-2008, we had major infrastructure improvements for bringing water for the city. And just to show that actually planning does make a change. If we look at the levels of major air pollutants as percentages of the air quality standards, which is a standard way of looking at it, both for particulate matter of 10 microns or 2.5, or for nitrous oxides, things are getting better, but still we're fighting with it, and especially for nitrous oxide, we're having problems. We're barely the average for all the city monitoring stations is now about what the European directive sets as a goal, which means that in some stations that's still not. On the other side, for drinking water standards, things really got better after this major drought and with the new plants that some of you may visit tomorrow afternoon if you sign up to the site visits related to water treatment and the desalination plant. So we had this problem with pollution in drinking water, essentially trihalomethanes, and we only got rid of it a handful of years ago. But we hope we are now fit for the future and able to confront what this means. Let me talk a little bit about vector control and mosquitoes. Now, the situation is not like in Rio. We got rid of malaria in this country in the late 50s, early 60s. We do have many malaria cases, but they are imported from travelers, from people who work abroad, from immigrants. But we haven't had, well, we've had a single case of malaria a few years ago that was not imported. So the potential is there. We have the mosquitoes and we have people who bring malaria. So if we have more mosquitoes, the potential for reintroduction is there. So we should be careful. And the presence of Aedes albopictus, which is an invasive species, we had not Aedes, but now, as you can see, in southern Europe, especially in Italy, in the former Yugoslavia, in Greece, and also in parts of Spain, including Barcelona, we have introduced Aedes albopictus. And this poses risk for arbovirus transmission. Now, we've had no native dengue, no native chikungunya, no native Zika, but we've had more and more cases of arbovirus that are coming. And last year there were about 75 cases of arbovirus imported into into the city, and about half, more or less, were viremic while they were here. So if a mosquito got a sample of that blood, it could transmit it potentially. And we've had to develop plans and investigate all these cases. And we have found infected mosquitoes in the households. No transmission yet, but it's happened in Italy, it's happened in southern France, it's happened in Greece. It's bound to happen here unless we are very active. So with malaria, we were able to get things better, but as you can see on the last years, it's rising again. So what remains to be done? I think from the perspective of public health services, we need to reinforce operational links with the city emergency plans. And it's important that we review and evaluate current heat wave plans and look what's inside the black box, because otherwise we won't be able to improve it. And to draft perhaps a specific information system with emphasis in mapping vulnerable populations. And this links well with our traditional emphasis in inequalities and in community programs. And with others, because a lot of the work, as it's been said before, is work that us as public health services are a tiny part of the city administration. But there are very relevant departments we need to explore and pilot changes in what is the breeding ground for mosquitoes. And we need to be very, very careful with this. As we had this presentation this morning from Richard, who said, we don't want to be able to say, oh, I told you. We don't want it to happen. We don't want it to happen. Now, with ornamental fountains, we have operational plans that are good, and so that's not expected to be a critical breeding ground for mosquitoes in the future. But for street drains, and there are thousands of street drains, many of the street drains that drain rainwater are very likely to become mosquito breeding grounds, and we would need to find alternative design options, and this requires piloting new schemes, testing them, and then changing a lot of the infrastructure in the city. We may have to deal with predictive models for vectors and arbovirus transmission. We have experts in town that will likely be able to help us at that. And perhaps we should promote pilot changes in the urban design to mitigate the heat island effects and evaluate how this happens in some vulnerable neighborhoods and whether it does change those critical degrees of temperature in the warm season. But this is, in fact, work in progress. This is part of what we were discussing in our cross-sectional working group, and we have to test it and conduct further. So we haven't finished yet, and perhaps after this session we'll have more ideas.
Well, thank you, João Ramon. This is terrific. We had 4 very, very good presentations, so thank you very much. And yours very much highlighting the long-term nature of building resistance in public health and how it's interlinked with many other sectors. So we have a couple of minutes for questions from the audience. So if anyone has a question, please step forward. And in the meantime, while you're being shy, I'll pose a question. Which is building very much on what you said about Richard's presentation, which was, I think, it marked us all to see that train track going into the sea. And how do you avoid this idea of, I told you so? How can we be more proactive in the public health sector in building resistance? And how can we, building on what Cindy said about telling the story and simplifying the science. And also, I think what Luciana, you started talking about is, working in the context of uncertainty. How can we tell our stakeholders, in particular our senior stakeholders that Richard was talking about, the decision makers, that we need to emphasize building preventive public health resistance? We don't have train tracks that are visible that we can show going into the sea. How can we simplify the story? Maybe Cindy, you have some thoughts on that.
I think, kind of as we said, we can't always wait for science. As we're looking at the Zika virus, we need to take action. And a lot of the public health benefits to climate change those types of strategies have co-health benefits. So as we're working to build climate resilience, we're also improving health, which is hard to argue against. I think working in a health department, we have a special role in protecting our citizens. And so moving forward with urban resilience and improvements to the built environment that improve air quality and build resilience against climate change are really hard to argue against. So I think using that public health or health background to move forward with the uncertainty of science is really important, and just not to be stagnated. I know, sometimes working the scientific community years and years to figure out cause and effect, and we're really not waiting for final evidence when we know that there's health benefits that can be achieved.
Any of the other speakers have a thought on that?
Yes, I'd like to say something. Yeah, agreed. Yes, I also the health co-benefits we must take in consideration. They are always numerous, but personally, I always emphasize the risk of ruin or the risk of collapse, or should everything go wrong. I think it's a part of the job, at least if there is a resilience officer, which I am. So part of me is to be clear, look, the risk of collapse is real. And I don't want to be a doomsayer, but this is exactly what we are trying to avoid. And I believe that the improbable happens too often. There are what's so-called the black swan events, that's the outliers. And we can always see in our history, either political or social history, but in terms of weather, why not? In terms of public health, why not? So, the risk of collapse is always there, so.
Great, thank you. Anyone else like to come in on that? It's very much risk management, as you talked about in the last session. Any questions from the floor? I think we have maybe 1 or 2 minutes left. Yes.
It seems to me that even in the health sector, the biomonitoring is not something that is widely used or that exists in many of our countries. And therefore, from the public health this area or vector, we are missing a lot of data. So to adapt, to transform, to avoid collapse, etc., we would need to know much better the quality of the data all across the European Union in particular, but in the rest of the world as well. I think there are, for biomonitoring, only 2 plans that exist in Europe, one in Germany and one in France at a various level of development. This is something that would certainly influence the public health if it were to be followed and monitored carefully. So there is also work to be done in the public health area if we want to address those issues.
Absolutely, thank you for that comment. Anyone else like to pose?
Thank you. I had a question for Cynthia as well. I'm really impressed by the collaborative work that you're doing and work in the communities. I'm wondering how you are reaching your undocumented residents. We find that one of our biggest challenges in Seattle.
Yeah, so in San Francisco, we have a strong history of working with undocumented workers as far as labor rights and health issues, providing health insurance. We primarily work with nonprofits who provide services to undocumented workers. So educating them. We are trying to find new ways to reach people, to alert them about potential emergencies around air quality or heat or storms, and we're thinking of doing some sort of smartphone initiative, because we found even though people are undocumented or maybe low income, they all have smartphones. So we're trying to find new ways to communicate directly with residents, whether they're documented or not, to inform them about health impacts.
Great. Well, I think we're coming to the end of our session, and I think what I'd like to do is suggest that if anyone else has questions for any of our wonderful speakers, that you buttonhole them during the lunch and continue the discussion. And I'd like to wrap it up by thanking very warmly our four speakers and thanking you participants. And of course the organizers, and saying that we've got another session now at noon that I think is starting on financing of resilience. And if anyone who walked in late is interested in staying in touch on public health, please sign the sign-up sheet, give us your email. We're trying to start a network of interested community of practice on public health. So yeah, so thank you very much, and see you.